they are sick. But if we look at children, those that have the COVID infections but have absolutely no symptoms, their viral load, that is the load of the virus in their secretions, seems to be much less when compared to adults. So we know that children, firstly, are not affected as much as adults. And secondly, when children get COVID infection, the majority of them usually have asymptomatic disease. So what are the symptoms that children present with? Now, for adults, we've heard about the typical symptoms, breathlessness, fever, and cough. But in a number of studies now in China and the US, we know that children very rarely would present with a fever. Only about 40% of children would have a fever. About half would have a cough. But the majority of children, unlike in adults, would have a red throat, sore throat, diarrhea, vomiting, a runny nose. So I think for school teachers, this is key. We shouldn't just think about just the cough. A child with a sore throat with a bit of diarrhea, runny nose should then be kept from school because they're likely to be infected. I think, skip that slide. Now, what I wanted to demonstrate here in this study that was published from the USA is if we look at the proportion of children that get infected and we look at different age groups, how many of these children would have significant and severe disease. If you look at that left-hand panel, you will see that for the children under the age of 1, the blue panel shows the number of children that would need hospitalization. The light blue, those who need to go to ICU. You can see that younger children are at actually more risk of having more severe disease requiring hospitalization when you compare them to the school-going children. A very small proportion of them would actually have significant disease and would need to be hospitalized. So we know from a large data set in the US of over 150,000 cases, only 2% of children actually required ICU, and only 1.7% of all children that actually got sick actually required to be admitted to hospital. So it's the younger children under the age of 1 that if they get infected, they have slightly more severe disease than the older school-going children. I'm not going to talk about protection because I think that Dr. Archery will cover that as well. So what I wanted to cover, which I think is a key question for many people, is which children are at highest risk for COVID-19. Now we know, as I've just shown you in the previous slide, younger children, particularly those under the age of 1. So children under the age of 5 proportionally are the ones that, if they get infected, they're ones that probably would be sick and be hospitalized, but a minority of them would need intensive care. Children who have chronic diseases in the chest, so children who have destroyed lungs with bronchiectasis, for example, we know that those children are at a slightly higher risk. But I want to stress, for children with asthma, there's now quite a lot of data around this. Asthmatic children who have mild asthma or moderate asthma don't seem to be at higher risk when compared to the rest of the population. So if you have asthma and the asthma is well controlled, these children are not at risk. They should be able to return to school because from data from Europe and the US, very, very few children actually had any significant infections with COVID-19 when compared to the rest of the population. We know from other viral infections, children who have heart diseases, severe neurological problems, those should probably be your high-risk group and should be protected. And what we were also concerned about as pediatricians was those children that have cancers and are on chemotherapy, etc. But there's been a study that was published actually a week or 2 ago from the US, where they've looked at children in a cancer clinic, and quite surprisingly and hearteningly, a very, very small proportion of these children actually seem to be affected by COVID-19, and very few of them actually required admission. So although these are a special category, the findings from this one study are quite heartening. And obviously, children that have on medication that suppresses the immune system, have diseases that suppress the immune system, we'd be concerned about those children as well. Now, I know that people have also read about this Kawasaki-like syndrome, which was in the New York Times. This was recognized in the UK and the US, was children presenting with this quite significant inflammatory syndrome requiring ICU. This, we think, is actually not just, it doesn't really happen in the acute phase of the disease when children first become positive for COVID-19. It's something that happens a few weeks later after the infection. But what I wanted to stress from this, remembering that children would only make up about 1% of the 1 to 5% of the population that would be infected with COVID infection. I've told you now about 2% of those children would probably need to be hospitalized. Very, 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 very few of these children would require intensive care. This disease, this multisystem inflammatory syndrome, is actually a very rare complication, which is found in a very small proportion of that even smaller proportion of COVID infections. Now, we must remember that keeping children from school isolates them. There's very little structure if children don't go to school. And there's been now quite a lot of data with a big study in China showing that a fifth of children, because of social isolation, develop depression and anxiety. And I think we should really take that into account when we're thinking that children should be kept away from school. So I just want to conclude by saying that COVID-19 affects a very small proportion of the population. If we're talking about children, they make up a very significant minority of the cases. If we look at the burden of disease, if children get COVID-19, the disease is usually asymptomatic or mild. So these children don't usually require to go to hospital, and a very, very small proportion of those that even go to hospital would require to be in an intensive care unit. We think that children are also not quite as efficient as adults in terms of spreading the disease, but we should also, again, be careful in the very young children who are not schoolgoers, and also those children who have other diseases that may put them at a slightly higher risk for getting COVID-19 and therefore more severe disease. I will stop there.
Great. Thanks, Prof. Motshekga. There are 4 questions that have come up that I think it'll be useful if we answer them now, if that's okay with you.
Absolutely.
So the first one is specifically about asthma, and I think your expertise as a pulmonologist would help a lot. One of the parents says here, how would you advise parents with children suffering from allergic rhinitis and asthma in view of COVID-19? Are these children allowed to attend school?
I think I'm going to stress again, because of the interest of time. There's been now a lot of data published, especially from the US, from Wisconsin, where they looked at people who have allergic rhinitis as well as allergy. And what they found is, unlike people who don't have allergies, that ACE2 receptor that I was talking about, people who have allergy and allergic asthma have an even lower level of the ACE2 receptor. So they seem to be at even lower risk than other children for getting the COVID infection, because that receptor seems to be lower in the airways. Secondly, there's been now a really good large data set from many, many countries in Europe where they pooled the data together and they wanted to categorize risks. And asthmatics, there were over 900 children in that study, and only 45 of those children actually tested positive for COVID, and they were also asthmatic, and none of those children actually required hospitalization. So again, if you have controlled asthma, and the child is not requiring to come to hospital many times, they have mild or moderate disease, and your doctor has seen your child and is quite comfortable that your child doesn't require to be admitted to hospital many times, it should be safe for that child with asthma to go back to school.
Okay, great. Thank you. The second question was on, you mentioned that the research is based on China and the Europe and the US. Given that we have very different situation in South Africa with TB and HIV, can we trust that research in South Africa? And does the existing research that we have in South Africa tell us anything about this?
Okay, that's a very good question. And of course, because we don't have a lot of time, I couldn't go a lot into that. Now, we know that China has a very different demographic. They have a one-child policy. So in China, you would have very small households. And in the Europe, of course, the dynamics are different, and we don't have the high burden of HIV and TB. Now, if somebody has TB and they have HIV and it's well controlled, that is, they've gone to their doctor, the viral load is suppressed, the child is well, we would think that that child it would be safe for them to go back to school. Of course, we don't have much data. And as I stated at the beginning, we've been 5 months into this disease, and there's very, very little data from Africa where there's a high burden of HIV and TB. So the simple answer is, unfortunately, from a scientific perspective, we don't have a lot of data, but we'll have to see as the disease evolves in our country, whether this would impact our patients differently, those who have TB and HIV. But if the person has well-controlled disease, they're not sick, the child is absolutely well, it would be reasonably, this is not based on any hard scientific fact, but it would be reasonable for that child to be able to go to school. And this I would base from the data around the children who had the oncological malignancies and other primary immune deficiencies. That data from Europe, they didn't seem to be at high risk of getting COVID-19.
Okay. The third question is about some of the data that you shared. Are the incidence rates lower for children simply because they were relatively more protected because schools were closed down? Is that the reason why we're seeing lower rates in children?
Well, I think that argument would probably, if that were true, the children don't live in isolation, they live in households. So if it would be logical that if you have an adult case who gets infected, that children would be infected as well. And we know there's very good data that adults in one family most of the time would not infect children in the same household. So of course we don't have data around schools, but we do have data around people living in the same environment. So I think that that argument can be argued against, because obviously children don't live in isolation, they live in households. And if there are people infected in the households, then they should be infected.
And I think we've also seen some data from countries where they have open schools, and we haven't seen big outbreaks linked to those schools, like in Sweden, for example. So the last question, Prof. Motshekga, I think you had a graph in your presentation. If you can just go back a bit to the UK and the rates of hospitalization and deaths relative to the age groups. I think it was one of the graphs that you skipped. One before this one.
No,
yeah, this one.
This one. Well,
yeah.
What I want
if you could just give us a breakdown of that graph, because I think it gives some solace to parents when they're seeing all of these rates of, hearing stories of people going to hospital and dying and things like that. Can you just describe and explain that graph on the right to us?
Okay, so on this graph, this is data from the UK. And this is data for people that were admitted, they had COVID-19, and these people were admitted in UK hospitals. And this is data from over 20,000 patients. And of those 20,000 patients, only 310 were children under the age of 18. And they made up, in terms of a proportion, about 1.5% of the overall infection burden of the UK. Now, if you look at the graph on the right-hand side, this shows the outcome. So what happened to these people who had COVID infections, who were admitted to a hospital, what happened to them? Now you see the pinkish is people that were discharged. The sort of orange is people who needed ongoing care, that they were still in the hospital at the end of the study, and the purple shows the people that died. So you can see that from this data from the UK, if you look at the bottom of the graph that shows children below the age of 19, you can see that there's none of the children died. very few of them were still getting ongoing care, and the majority of them were discharged. So really the message from this very large study is children generally do very well, even if they get admitted in a hospital, their outcome is good. Remembering a small proportion of children would actually be admitted with COVID-19.
Thanks, Prof. Motshekga. I think what it also shows is just that it's so rare that children do actually get severely ill with COVID-19, that they need to get admitted to hospital. This seems like an extremely rare disease for children and specifically, whereas for old adults, it's obviously not very rare, based on this data that you're showing. Yeah. So thanks so much for that presentation. I think we're going to hand over to our next speaker now. And Prof. Motshekga, feel free to answer the Q&A in the Zoom. I think Mo has been doing a great job of just answering some of the questions that the panelists have just while we're going along. So the next presentation will be by Prof. Stempiso Velapi. He's a pediatrician. He's an associate professor with the University of Witwatersrand and the head of pediatrics at the Chris Hani Baragwanath Academic Hospital. So I'm going to hand over to you, Prof. Velapi. If you can present for about 15 minutes, and then we'll have 5 minutes for question and answers. Thanks. And I think you might still be muted, Prof. Velapi. Okay, I've unmuted you. We should be able to hear you now.
Good morning to everyone, to my colleagues and to the people who have joined the webinar. Prof. Motshekga has covered most of my presentation, but I'll go through what I have. And I think I'll say overall, I fully agree with what she has said. So I've tried to look at the question that whether children are more susceptible to coronavirus infection and are they super spreaders. Next slide. So I'll address these two questions in the next slides, 15 to 20 slides. Next slide. So the studies that have looked at whether children are susceptible to infection than adults, one can divide them into two groups. One group is what we call a population surveys. The other one is contact tracing, where there was a patient, a case, which was an index patient who had diagnosed with COVID-19, and then looking at the people who were in contact with that individual as to how many got infection, and also comparing the adults and the children. Next slide. So looking at this slide, again, Prof. Motshekga has referred to this slide already. This was a study looking in Italy. So the first survey was done just before they came with lockdown. As you can see in this study is that less than 10 years old, no children were positive. 11 to 20 years, 1.2% were positive, looking at the first survey. Now, one would have thought with the subsequent survey, things would be different. But of course, they implemented a lockdown. So with the second survey after the lockdown, we can see again the children less than 10 years old, none were positive. And then 11 to 20 years old, it was still a similar number or a bit less at 1%. So in summary from this study is that proportion of infected children was less than that seen in adults, suggesting that the children are less susceptible to infection than adults. Next slide. So another study from Iceland. So if you look on the first panel on the left side, the A and D, this was looking at children or the whole population, but focusing on those who had the symptoms or those who had a conduct. Again, looking at the children who were tested, the number that was positive was about 7%, But if you compare to the adults 40 to 60 years old in the bottom block at D, you can see the numbers that were positive were much higher. But even if you look at, then also at a group where they just look at the whole population, asking people to volunteer the information. So the B and E is a group of people who are not having symptoms. So when you look again in that group at the bottom graph E, there are fewer children who had the infection, again suggesting that the children are less susceptible to infection. The next slide. But subsequent studies to that coming from many countries, Sweden, Germany, Switzerland, Netherlands, United Kingdom, and Spain, with varying number of people who were tested. So looking at Sweden, the results that there were no differences between children less than 16 years old compared to adults who are 30 to 59 years old. And then in Germany, the number of proportion of children who were positive, relatively less than those who were more than 15 years old. Switzerland and United Kingdom, the numbers were similar between children and adults. And then looking at Spain, looking at children who were less than 1 year, 1% were positive. And then there was a slight increase with each age category in terms of the infection, again suggesting that the susceptibility might increase with age. Next slide. But if you put them all these studies together, as you can see, some are saying similar, some are saying less susceptible. If you put them all together, what is called meta-analysis. Overall, these studies, which are population surveys, did not show a difference between children and adults in terms of susceptibility. So if you look at those bars or blocks, there's a straight line which goes straight crossing 1. So if that bar is straggling 1, suggests that there's no difference between children and adults in terms of susceptibility. So, but these are population surveys that you're not looking at people, you don't know who was exposed, who was not exposed. People are just feeding you the information. But then the other group of studies were then actually looking in households or looking at people who had contact. Next slide. So this study, the study that look at children and adults who had a person with infection. So if you look then in the first group, the first 2 age group categories, 0 to 9 years old, 7.4% of people who had a contact became positive. And then if you look at 10 to 19 years old, 7.1% were positive. But again, if you compare with the adults overall, this study, even looking at the contact tracing, suggested that there's no difference between children and adults in terms of their susceptibility. Again, if you look at the last column, what you're looking at the odds, if the numbers in brackets are straggling the number 1, it suggests that there's no difference if you compare those age groups and the age group of 50 to 59
Getting
years.
Children back to school safely. Important topic given the current situation that South Africa is dealing with regarding COVID-19. This is a Human Science Research Council webinar on that topic about how to get schools or how to get children back to school safely. And some of the conclusions that were drawn and you heard was that children constitute a small proportion of cases. Most children have mild symptoms or asymptomatic. Majority of children will not require hospitalization. Most children not efficient spreaders of disease, and the other important point is that care should be taken in very young and those with comorbidities. Some conclusions drawn from this Human Science Research Council webinar. We'll have much more in our later bulletins. It's a wrap of the agenda. The news continues. I want to hand it over to the On Point team. Have yourself a great day, folks. I'll talk to you tomorrow. Take care. Bye-bye.